Hi students, so in today's session, let's discuss about abnormal labor. So before understanding what is abnormal labor and what are the abnormalities that can happen in labor, let's have a brief understanding about normal labor. So in normal labor is basically divided into 4 stages. There is first, second, third and the fourth stage. So first stage is basically when the cervical changes begin till the time of full cervical dilatation. So first stage is basically from the beginning of cervical dilation, till there is complete dilation. We start from 1 centimeter, then we reach till 10 centimeter. That is included in the first stage. So first stage can be again divided. It can be again divided as either the latent phase. The next is the active stage. Active phase and latent phase of labor. I will soon tell you how to differentiate this latent phase and active phase. As of now, understand that the first stage is divided as latent phase and active phase. The next is second stage. So currently the cervix is fully dilated. So from the time of full cervical dilatation till the fetus is expelled constitutes the second stage. So what is second stage? This is from full dilatation till expulsion of fetus. Alright. So the second stage can be again divided as passive as well as active. It can be divided as passive as well as active. Passive means at that time the mother is passive. She is not pushing. So second stage is again divided as latent phase and active phase. So active phase is when the patient is actively pushing, whereas latent phase is when she is not pushing. So basically it is divided into 2. Now the third is we have the third stage. So next we have the third stage of labor. So third stage of labor is basically after the expulsion of fetus till the expulsion of placenta happens. So first the cervix has become fully dilated. This was the first stage. In the next stage, the fetus got expelled. In the third stage, we are waiting for the placenta to get expelled. So third stage is from the time of fetal expulsion till the time of placental expulsion. This is the third stage. So finally, we have the fourth stage. So fourth stage is the 2 hours following the delivery where we actively monitor the patient, during which time the uterine involution starts. So as of now, we have brought this new term, that is the fourth stage. Previously, we used to call till only first, second and third stage. Currently, we have included the time after delivery as fourth stage because this is a very important time. This is the time where there is a possibility that the patient can again have bleeding, she can have complication. So in this fourth stage, we actively monitor the patient. We are going to actively monitor this patient. If she develops any complication, we would be assessing for the tone, whether it is well retracted. We assess for her blood pressure, vitals, we check for BP, and this is considered to be the fourth stage of labor. Alright. Now coming to each of the phase. So I told you the first stage is again divided as active and passive phase. So the definition of active phase has been continuously evolving. Previously, as per the WHO partogram or previous WHO partogram, which is known as the modified partogram, it was divided as 4 centimeter. The cutoff was 4 centimeter. So, more than or equal to 4 centimeter was active phase. Less than 4 centimeter was the latent phase. This is the WHO partogram which is being commonly used. That is the one most commonly that we follow. That is the modified WHO partogram. But recently, there has been another partogram which is launched by WHO. It is known as the next generation partogram. The next generation partogram. So, as per this, the cutoff for active phase is, it is more than or equal to 5 centimeter. Less than 5 centimeter, it is latent phase. As per the recent ACOG guidelines, again, there is a slight change. The cutoff is more than or equal to 6 centimeter, whereas less than 6 centimeter, it is considered as passive phase. So, why is there so many cutoffs and changes that is happening? So, at the beginning, it was thought that the active phase started from 3 centimeter. Then we did so much research, then gradually it shifted to 4 centimeter. Active phase is the time once the patient enters the active phase, the rate of progress is going to be faster. So, we saw that by many studies, the rate of progress was not that much after once the patient has crossed 4 centimeter. The rate of progress was at least 1 centimeter per hour once the patient has reached 6 centimeter. Only after that time, we can consider this rate of increase of 1 centimeter, and that is why there has been changes that is happening. It is after a lot of studies, gradually it has been evolving. So currently what is taken is 6 centimeter. So in your question, if there is nothing given, they are just asking you when does the active phase start, you can go with 6 centimeter. If they provide you with the modified WHO partogram. So here I am showing you the image of modified WHO partogram. So here in this, if they ask as per the modified WHO partogram, the cutoff is 4 centimeter. If they specifically ask you what is the active phase as per the next generation partogram, only then you are going to choose 5 centimeter. So if nothing is given or specifically ACOG is given, go for 6 centimeter. As for all practical purposes also, we take it as 6 centimeter. If the question is based on modified WHO partogram or they just give you a partogram and ask according to it, take it as 4 centimeter. If only they specifically mention it as next generation partogram, then go for 5 centimeter. Alright. Now, coming to the abnormalities in each of these stages. So, I told you the first stage is divided as latent phase as well as the active phase. So, there could be problems in the latent phase. The latent phase could be prolonged. The duration of latent phase could be prolonged. So, let's see what is the normal duration of latent phase. The normal duration of latent phase is slightly different in primigravida as well as multigravida. In primigravida, the cutoff is 20 hours. It is 20 hours. Beyond 20 hours, if it goes, we'll call it as prolonged. In multi, it is slightly lower. That is more than or equal to 14 hours. If the duration is more than or equal to 20 hours in primigravida or more than or equal to 14 hours in multigravida, then you are going to call it as prolonged latent phase. You are going to call it as prolonged latent phase. This is the definition of prolonged latent phase. So, why does this happen? Let's see the causes. So, it could be either due to an unfavorable cervix. It could be due to that the cervix is unfavorable and that is why it's not getting dilated well. So, it could be due to an unfavorable cervix or it could be due to the fact that we are giving the patient excess sedation or the patient is on epidural. The medicines that we are giving, epidural or sedation. Sometimes the patient comes with pain and after we monitor, we understand that there is contractions are subsiding, the cervical changes are not progressing. So, these changes are not progressing and then we call it as false labor. She had some pain, but it was not due to the labor pain as such. So, when it is a false labor, again, the latent phase could be prolonged. If the patient has an abnormal lie or position, such as a transverse lie or an occipito-posterior position, In these conditions also, the latent phase is going to be prolonged. So these are the few of the causes of prolonged latent phase. So now let's see, if you see that a patient is in prolonged latent phase, what are you going to do? So suppose a patient has come and you see that in a primigravida, the timing of the latent phase is more than 20 hours, and in multigravida, it is more than or equal to 14 hours. That is, during this time, she is less than the active phase dilation. So now what are you going to do next? So the next thing is, let me give you the options. Are you going to do a cesarean for her? Are you going to induce her? Are you going to augment her? Or are you going to just wait? So the answer here would be, you don't do a cesarean section. You don't never ever do a cesarean section for just a prolonged latent phase. So what are you going to do? So cesarean is totally out. What you can ideally do is, in the meantime, you can just give sedations, adequate pain relief to the patient and ask her to rest. And we will wait and watch. So we wait. We give the patient adequate rest. We give the patient analgesics. We give the patient painkillers as well as sedation as required, so that the patient just sleeps, so that she's undisturbed, and we are undisturbed. We give her sedation, we give her analgesics and let her wait. Usually, once she sleeps and wakes back, by the time she would have gone into active stage, or the dilation would have progressed more. So usually this is the only management that you are going to give. Suppose even after that time, you waited for 6 to 8 hours when she is sleeping, and despite that, she is still having pain. She is still in the latent phase. She has not progressed into active phase. Then you can consider her for oxytocin administration. So if I ask you which is never done, cesarean is never done. So the best management would be to just wait, give her rest, give her analgesic, give her sedation and just wait. Suppose she is not relieved by that, she is still having pain, then as a final resort, you would augment the labor with oxytocin. Alright. So let's have a look at this question which had come for the previous NEET exam in June. So there is a 25-year-old woman who is visiting the labor room at 36 weeks. She has mild labor pains for 10 hours. The cervix is persistently 1 centimeter dilated and uneffaced. So the cervix is persistently dilated 1 centimeter only and it is uneffaced. What is the management in this condition? So ideally, the management would be just wait. It is not even prolonged. I will tell that she is prolonged latent phase if it is more than 20 centimeter in a primary, more than 40 centimeter, more than 14 hours in a multi, more than 20 hours in case of a primary. So in this case, I will just wait. But as the patient is having labor pain and there is no change, the next thing that can be done is wait. Along with that, give her some relief medications such as give her sedation. So the answer here is sedation and wait. You are not going to give augmentation with oxytocin. You are not going to do ARM. LSCS, never. You are not going to do that either. So you are just going to wait for this patient. You would wait and watch and maybe give her sedation as well. So that is the correct answer in this. Now coming to the active phase. So the active phase of labor, again, the problems in active phase can be divided as two. Either it can be a protracted active phase or disorders of protraction, or there could be arrest of active phase. Protraction means it's similar to prolonged. As for active phase, we use the term protraction. That is, the rate of dilatation is not as much as we expect. So let's see what is the rate of dilatation that we are expecting. So in case of a primigravida, in case of a primate, we expect the dilation to be at least 1.5 centimeter per hour. Whereas in case of a multi, what we expect is 1.2 centimeter per hour. Always in multi, it's going to be slightly less because we are expecting they will progress fast. So that expectation is not met at a lower cutoff. For primate, it is 1.5, whereas in multi, it is 1.2 centimeter. Alright, this is ideally what we are expecting. We say that the active phase is protracted if the rate of dilatation is less than 1 centimeter. The WHO has given the cutoff of leave 1.5, leave 1.2. At least the woman should dilate 1 centimeter, whether it be multi, whether it be primate. So, if the rate of dilation is less than 1 centimeter per hour, so if the dilation is less than 1 centimeter per hour, we call it as protracted active phase of labor. It is known as protracted active phase of labor. So now let's discuss about the arrest of active phase. So basically, the dilation of cervix has stopped. The dilation, there is no significant increase in dilation or the cervical changes after some criteria as well as after some hours. Let's see them in detail. So basically, arrest of cervical dilation means that there is no significant dilation. There is no significant dilation in a patient in whom amniotomy has already been done. So amniotomy is done, ARM has been done, and there is no dilation for a period of 4 hours. For a period of 4 hours, there is no dilation in a patient who is having adequate contraction. For a patient who is having adequate contraction. Whereas, it is more than 6 hours in a patient who is not having adequate contractions. So, with inadequate contraction, it is 6 hours. As for a patient who is having adequate contraction, in whom already amniotomy should be done, she is not dilating after a period of 4 hours. That is arrest. If the patient had ARM, she is not dilating after 6 hours. That is, if she is having inadequate contraction, we wait for 6 hours. That's it. So, we can write it as there is no dilation, no significant dilation or cervical changes in a patient who is having, in whom ARM has been done, in whom there is adequate contraction, we wait for 4 hours. In a patient in whom there is inadequate contraction, we wait for 6 hours. This is adequate. Adequate contraction, we wait for 4 hours. Inadequate contraction, we wait for 6 hours before calling it as arrest of active phase of labor. Alright. So, you know that for a normal labor to progress normally, the 3 P's has to be normal. The 3 P's are the power, passage and the passenger. The power, passage and the passenger has to be normal. So, what is the power? That is the uterine contractions. And finally, the pushing of the mother as well. So, it's the contraction and the pushing from the mother. Next P is passage. So, passage basically means the pelvis as well as the soft tissue resistance through which the baby is passing. So, the second P is the pelvis. The third P is the passenger, that is the baby. What is the size of the baby? Any problem in any of these, there is going to be problems during labor. So, all these are causes for protraction of the active phase as well as there could be arrest of active phase due to this. Let's see the problems one by one. So, the problem could be at the level of power, the problem could be at the level of passage or at the level of passenger. Let's see them. Now, coming to the causes. So, the problems can be either at the level of power, passage or passenger. So power means basically the uterus is not contracting adequately. Either it could be due to the fact that she has received from some tocolysis. Tocolysis are the medicines that helps to relax the uterus. Either she has received some tocolysis or the patient is not contracting despite us giving her oxytocin also. Despite giving adequate oxytocin also, she is still having inadequate contraction. She is not getting adequate contraction. She is not having adequate contraction. Next is the fetal or the passenger. So, the passenger problems can be either the baby is too big, that is macrosomia, or the baby's position is not so good. That is, either it could be occipito-posterior or the head could be deflexed. These are the conditions. So, in case of passenger, it could be that the passenger is too big, such as macrosomia, or the baby is not in the right position, that is occipito-posterior, or it can be deflexed head. So, when the baby's size and the pelvis is not matching, we call it as CPD or cephalopelvic disproportion. There is some disproportion between the pelvis as well as the baby, due to which the baby is unable to negotiate. The power, the passage and passenger has to be normal. In CPD, either there is a problem with the passage or with the passenger. So, CPD is another cause. Finally, coming to the pelvis, that is, we have a contracted pelvis or there is CPD. CPD comes under both. Alright. So, till now, we were speaking about adequate contractions. So, what is meant by adequate contractions? So, there should be at least 3 to 4 contractions. There should be at least 3 to 4 contractions lasting for a period of 40 to 45 seconds over 10 minutes. If there is this much contraction, we call it as the contractions are adequate. At least 3 to 4 contractions lasting 40 to 45 seconds over a period of 10 minutes. These are adequate contractions. So, as to assess the contractions, we have another unit as well. This is what we are clinically judging. But with tocometer, that is by measuring the contraction, we can assess exactly how much it is. This is known as Montevideo units. Montevideo units. It is basically the intensity of contraction multiplied by the number of contraction. The intensity of contraction multiplied by the number of contractions. At least the Montevideo units has to be more than or equal to 200 millimeter of Hg. 200 millimeter of Hg means the contractions are adequate. 200, I told you, nearly there would be 3 contractions. So, 3 contractions, so approximately at least it has to be 60 to 70. One contraction has to be at least 60 to 70. So, now it will be approximately 200. So, for 3 contractions, at least the pressure has to be 60 to 70 millimeter of mercury. We measure this with the tocometer that is present in the labor room. So, it can be either done clinically, which is the most common clinical practice. In some centers, we can measure it through this as well, which is Montevideo units. Alright. So, if you see here, the question gives a primigravida who is 39 weeks in labor and on admission, her PV is already 6 centimeter. She is getting 2 contractions in every 10 minutes. She is having contractions, but it is only 2 contractions. And over the past 4 hours, her cervical dilation is 7 centimeter. Her cervical dilation is only 7 centimeter over the past 4 hours. That is, she has been 6 centimeter. Over the past 4 hours, it has now become 7 centimeter. So, it is definitely not an arrest. There is some dilation. But you see that the dilation is less than 1 centimeter per hour. But here, she is not having adequate contraction. Her contractions are not adequate. So, what are you going to do? Are you going to do cesarean straight away? No. As the contractions are only not adequate, we are going to give her oxytocin. So, in case of prolonged active phase, you again reassess the power, passage and passenger. As for passage, you can't do anything. Once the pelvis is contracted, you can't correct that. But some degree of this deflection, some degree of this occipito-posterior and all will respond with the contraction. There is a possibility that the head flexion becomes alright. The occipito-posterior will rotate. When there is mild CPD with the oxytocin, it can negotiate into the pelvis. So first rule out that there is no severe CPD. There is no 3+ caput and all. There is no severe caput. That means there is an obstructed labor. There is no 3+ caput. There is no contracted pelvis. If that is the case, then in that case, we can try for augmentation of labor. So the first step that we are going to do in that case is ARM. Augment the labor. The answer would be ARM better than oxytocin. We will augment with ARM plus oxytocin. That is the ideal answer. But sometimes that might not be there. If ARM is there, first go for that. If ARM is not there, go for oxytocin. ARM, then oxytocin. Suppose, in the same scenario, if they are giving you that the head is high, I told you mostly it is ARM first, then oxytocin. But if the head is high and you do an ARM, the cord can prolapse. There is a chance that the cord can prolapse. So, only in case when the head is high, in that scenario, you are going to go for first oxytocin, let the head come down, then go for ARM. This is how you manage a prolonged active phase as well. So, prolonged active phase, you manage like this. Arrest of active phase, you have to definitely do cesarean section. Now coming to the second stage of labor. So, what is second stage of labor? Second stage of labor means basically the cervix is fully dilated. The time since the full dilation of cervix till the expulsion of the fetus. So, again, the definition of the second stage has undergone various changes. The normal second stage, the minimum, the mean duration of second stage that we are expecting is 50 minutes in case of a primigravida. This is the mean duration that we are expecting. Mean duration that we are expecting is 50 minutes in case of a primigravida and 30 minutes in case of multigravida. This is the ideal scenario. This is the ideal one which we are expecting. But you know that in today's era, the levels of cesarean are increasing. So initially it was thought like this. 1, 2, 2 and 3. That is, in primigravida, in multigravida, it is 1 hour normally. In primigravida, 2 hour normally. Along with epidural. This is without epidural. This is with epidural. With epidural, you add +1. That is, the 1 becomes 2, 2 becomes 3. This was the previous definition. But as I told you, the cesarean sections are increasing and we found that we can wait a bit more in the second stage. We want to prolong or push the definition of the second stage a bit more so that we don't rapidly jump into a cesarean section. During this time, there is possibility that the baby can negotiate, the baby can deliver and we can avoid a cesarean section. So again, as per the latest definition, the changes are, just add 1 more to all these. Very easy. Initially it was 1, 2, 2 and 3. Currently it is 2, 3. So +1 would be 3 and 4. Let me write it. This is for multigravida. This is for primigravida. This is without epidural. And this is with epidural. So, I'll make this clear. This is without epidural. This is with epidural. Again, this is without epidural. This is with epidural. So, Without epidural, let's study that first. Without epidural, in a multi it would be less. So it is 2. In a primi it is 3. Now just add +1 to it. Epidural means always add +1. It is 3 and 4. 2 becomes 3, 3 becomes 4. These are the cutoffs of the second stage which is being used now. These are the latest ones. These 2, 3 are hours, okay? That means 2 hour, 3 hour, 3 hour, 4 hour. So, in a patient who is a multigravida without epidural, we can wait for 2 hours. In a primigravida without epidural, we will wait for 3 hours. With epidural, we will wait for 1 more hour each. If it goes beyond that, then we call it as second stage arrest. Then we call it as second stage arrest. So what are the options in case of a second stage arrest? Once second stage arrest happens, we have to deliver the patient. We have to deliver the patient. So again, we would be checking the power, passage and passenger. All of that has been checked. We will make sure that the contractions are also adequate. But despite this, there is second stage arrest. So now we have to deliver the patient. Either we can do it by cesarean section or we will go for instrumental vaginal delivery, depending on the situation. Either we can go for a cesarean section or go for an instrumental vaginal delivery. So, in cases where the head has come down, that is, the station of the head is +2 or more. The station of the head is +2 or more, then we can try for a instrumental vaginal delivery, either a forceps or a vacuum. Along with that, all the criteria for instrumental vaginal delivery should also be fulfilled. I have taken all the criteria and details about instrumental vaginal delivery in the same chapter. Please refer to that. But now understand that if the head of the baby is way down and all the criteria for instrumental vaginal delivery is fulfilled, then you can go for instrumental vaginal delivery. If not, if the criteria are not fulfilled or the head is way up, it is above +2, it is above +2, or there is any contraindication for using instrumental vaginal delivery, or you see that there is significant CPD. There is significant CPD. It can be either in the form of significant molding is there, significant caput is there. Then you are going to deliver the baby by cesarean section itself. So, in the second stage arrest, what you have to do is you have to deliver the baby. Just choose either it is cesarean or instrumental vaginal delivery. Head of the baby is way down. There is no contraindication for instruments. Go for instrumental delivery. Head of the baby is up. Along with that, there is some contraindications for using instrument, or there is CPD where you can't pull the baby from below. In that conditions, you go for a cesarean section. Alright. Now, finally coming to obstructed labor. Obstructed labor means that the labor, there is problems with the progress of labor. The labor is basically obstructed. So, power, passage or passenger. The problems could be at each of these levels. So, what are the signs or symptoms that show you that probably the labor is obstructed? Obstructed means the baby cannot negotiate through the pelvis. The baby cannot negotiate through the pelvis. So, the clinical features that can be seen in obstructed labor is that either the patient can be exhausted. The patient can be exhausted. There can be dehydration because she has been in labor for such a long time. She can have dehydration. There could be tachycardia due to that. Due to increased pain and dehydration, she can experience tachycardia. She can have prolonged pain which is not relieved in between. So what happens is when the uterus starts contracting continuously so as to push the baby out. So in that situation, the uterus is not relaxing as such. So this prolonged pushing can cause prolonged pain in the baby. Prolonged contractions can cause prolonged pain in the patient as well. On examination, On examination, you can find that the patient can be dehydrated. There could be dehydration. There could be tachycardia. There is a typical sign which is seen on palpation of the abdomen, on palpation of the uterus. You find that the uterus is tender. Along with that, you find a pathological retraction ring. A pathological retraction ring can be found. It is also known as Bandel's ring. What is this? So basically, Bandel's ring, there is this upper segment and there is this lower segment. So usually what happens in normal labor, let me show you. In normal labor, the upper segment will contract and go down. The lower segment is going to increase. It is going to dilate and it will accommodate the fetal head that is coming down. This is happening during the labor. The lower segment will get thinner and thinner as the dilation progresses. But in this case, the upper segment is contracting. It is tonically contracting so that it becomes thicker and the lower segment becomes very thin. It becomes very thin. And there is a characteristic demarcation that is felt between the upper segment and lower segment. There is a characteristic demarcation or a ring that is felt between the upper segment and lower segment. This is known as Bandel's retraction ring. It's known as Bandel's ring. So, it can be felt per abdominally as well. When you do per abdominal examination, you can feel that there is this depression between the upper segment as well as the lower segment. This is the Bandel's ring. Yes, again, this is a picture which is showing the upper segment, lower segment. There is a depression in between which can be felt abdominally. Let me show it here. So, this is known as Bandel's ring. Now, management of obstructed labor. So, once there is obstructed labor, that means the fetus cannot come out. There is obstruction. So, in obstructed labor, the treatment is Cesarean section. Go for Cesarean section in such case. What will happen? What are the complications? The uterus can rupture finally. The uterus can rupture. There can be intrauterine death. So, we don't wait for that. We go for a Cesarean section once the diagnosis of obstructed labor can be So, we go for Cesarean section once the diagnosis of obstructed labor has been made. Finally, coming to the third stage of labor. So, third stage of labor is basically after the expulsion of baby till the expulsion of the placenta. So, in this third stage, you might know that we are not waiting passively. Either in the third stage, we can wait passively, that is passive management of third stage of labor, or we can go for an active management of third stage of labor. I have taught you in detail what is active management of third stage of labor in the topic of PPH. Let me quickly summarize this. So, in that, after the delivery of baby, we are giving the patient oxytocin. We give a controlled cord traction to the umbilical cord. Along with that, we do a delayed cord clamping as well. Third, we vigilantly monitor the tone of the uterus. We assess the tone of the uterus. If the tone is decreased, we go for a uterine massage. This is basically the active management. We are not doing anything. We are waiting for the placenta to deliver on its own. That is passive management of third stage. If we are actively intervening, the third stage maximum duration should be only 30 minutes. If we are not doing anything, it is 1 hour. If with active management, placenta does not deliver by 30 minutes, or the third stage without the passive management, the placenta does not deliver by 1 hour, we call it as prolonged third stage of labor. So, in that condition, how to manage retained placenta, we have discussed in the chapter of retained placenta. So, basically, you just understand these definitions. More than 30 minutes in active management, that is prolonged third stage. Then we diagnose retained placenta. Alright. Now, how does this placenta separate? So, we know that the placental separation occurs through a layer of fibrinoid degeneration in the placenta known as fibrinoid degeneration. So we know that in the decidua basalis, in the layer of decidua basalis, if this is the placenta, this is the umbilical cord, this is the decidua. In the decidua, there is a layer which is known as fibrinoid degeneration. So let me orient you. This is the umbilical cord, this is the fetal surface, this is the surface that is attached to the uterine wall, and this is the decidua. In between there is fibrinoid degeneration layer, and through this layer the placental separation is going to happen. For any of you finding it difficult to follow it, please refer back to the topic of placenta. Development of placenta, I have explained it in detail with pictures, how the development happens, how this differentiation happens, where the fibrinoid degeneration layer is. So as of now, understand that there is a layer of fibrinoid degeneration. It is known as the Nitta-Busch layer. Nitta-Busch layer. And it is through this layer. Let me write it clearly for you. Nitta-Busch layer. So it is through this layer that the placenta is going to separate. So there are two types of placental separation. So the placental separation can be either a central separation or a peripheral separation. Peripheral separation means if this is the placenta that is attached to the myometrium, that is attached to the uterus, the separation is occurring from the periphery. It is starting separating from the periphery. Whereas in central separation, the separation is right from the center, not from the periphery. So let's have a look at this picture. This is the central separation. So this is the central separation in which you can see that from the center, the separation has started. So the placenta is coming out like this, but the periphery is still attached. Whereas in peripheral separation, the separation has started from the periphery. Alright. So, there are various terms for each of these. The peripheral separation is also known as Matthew-Duncan method of placental separation. It is Matthew-Duncan type of placental separation. Whereas, central separation is also known as Schulz separation. Schulz separation. Matthew-Duncan as well as Schulz separation. So, while you see the part of the placenta that comes out, which is the part of placenta that is going to come out in each, that comes out in each of these. So, if you see the central separation, you can see that this part is coming out with the cord. This is the fetal surface. So, in this, the fetal surface will be seen first. Fetal surface. Fetal surface is usually the shiny grey surface. It is the shiny grey. It is the shiny grey surface. It is the shiny surface. Whereas in case of peripheral separation, that part that comes out is the maternal part, is the one that you see. The maternal surface is seen, and the maternal surface is usually dull red in color. Dull red in color. So, you can remember that dull red, looks like dirty, right? So, D for D. Matthew-Duncan's method of placental separation is for the dirty side that comes. That is the maternal side. That is also known as peripheral separation of placenta. Whereas center, C and S matches, also the shiny surface matches. C, central, Schulz separation, the shiny surface, shiny grey surface is going to come out. Alright. So, the bleeding is going to be more. You look at this diagram here, the bleeding is initially confined to this. You don't see the bleeding outside. Only once this periphery is going to separate, the bleeding would be seen outside. Whereas, in peripheral separation, the bleeding is seen early itself. And the bleeding is also more in case of peripheral separation. The bleeding is less in case of central separation. Okay, now that we are discussing about the third stage, let's quickly have a look at the types of perineal tear as well. So, there is going to be some perineal tears, and let's just divide what are the types of tears that can happen. So, either it can be a first degree, second degree, third or fourth degree tear. Okay. First degree tear basically means that there is discontinuity or tear of either the vaginal mucosa or skin. In this, either this vaginal mucosa or the skin outside, either one of them is torn. That is, either or both can be torn also. If only the skin as well as the vaginal mucosa is torn, that is known as first degree tear. But suppose along with it, just below that, who's there? There is perineal muscles. If the perineal muscles are torn along with it, it is known as second degree. Once the perineal muscles, you can see the muscles here, once the cut is a bit deeper, the muscles will also be cut. So in that case, the tear is known as second degree perineal tear. Remember that all the episiotomies that you give are going to be second degree perineal tear. They would be tear of both the skin, mucosa as well as the muscles. Now coming to the third degree perineal tear. So in third degree perineal tear, along with this, the anal sphincter is also torn. The anal sphincter is also torn. So below this, who is there? There is anus. So if the tear is extending below, there is anus, and above anus we have the anal sphincters. So the anal sphincters are torn in case of third degree perineal tear. And the third degree perineal tear has been further divided as A, B and C. A is basically when less than 50% of external anal sphincter is involved. More than 50% of the external anal sphincter is involved, that is B. So whole of external anal sphincter is over now. What is left? What is below that? There is internal anal sphincter. There is internal anal sphincter. If internal anal sphincter is involved, that is C. Finally, coming to the fourth degree of perineal tear. In fourth degree of perineal tear, what is the last structure? That is the anal mucosa. The anal mucosa which is there is also torn. It is complete perineal tear. Completely, right from the vagina till the anus, completely it is torn. So, if the anal mucosa is torn, anal mucosa is the one. If the anal mucosa is torn, it is known as fourth degree perineal tear. So now coming to the fourth stage. So in third stage, basically the placenta is expelled. So fourth stage is the time since the expulsion of placenta till 2 hours. That is 2 hours after the expulsion of placenta. 2 hours after expulsion of placenta. So in this time, we are going to vigorously monitor the patient. This is the time where the tone of the uterus comes back to normal and the process of involution starts. So the tone of the uterus is going to come back to normal. So what are you going to check during this time? In this time, you have to check the pulse, the BP. We have to check what is the tone of the uterus, and all these we are going to assess every 15 minutes. Every 15 minutes, you will check her for the next 2 hours. It was found that we were very much vigilant till the third phase. After third stage, we just leave the patient. And that is when the complications were also seen. So, they brought in the concept of this fourth stage where also we are actively monitoring. So, every 15 minutes, we are going to actively monitor her. We are going to check her pulse rate, BP, uterine tone and take actions immediately as required. So now let's summarize all the points and important values that we have seen in this chapter. So many students find this topic confusing and difficult, but this is going to help you a lot. So basically the abnormal labor, normally we have the first stage, the second stage, the third stage and the fourth stage. What is first stage? Basically it is from the cervical dilation till we reach 10 centimeter or till full dilation. Onset of cervical changes till full dilation is the first stage. Second stage is from full dilation till the expulsion of fetus. Till the expulsion of fetus. Third stage is till the expulsion of the placenta is complete. till the expulsion of placenta is complete. Fourth stage is basically 2 hours. It is 2 hours after the placental expulsion. 2 hours after placental expulsion. So, these are the 4 stages. Now, what are the normal duration of each of these? So, first stage in a primigravida, the normal duration that we expect is up to 20 hours. In a multigravida, it will be less. It is 14 hours. So, if it is more than this, we are going to call her as protracted. It is protracted latent phase of labor. This is basically about the latent phase of the first stage. This is the latent phase. What is latent phase? The latent phase, as per the newer definition, is less than 6 centimeter, the one that is given by ACOG. If the question is just giving you what is the active phase, you will tell that it is more than or equal to 6 centimeter. If the question is specifically asking you as per the partogram or WHO modified partogram, you always consider it as 4 centimeter. If the question is asking you regarding the next generation partogram, then you go with 5 centimeter. So, next is the active phase. So, in active phase, the rate of dilation in a primigravida, what we expect is 1.2 centimeter per hour. In multi, it is going to be faster. So, that is 1.5 centimeter hour. She is going to dilate 1.5 centimeter per hour. Here it was 20 hours and 40 hours. In active, it is as per hour. The minimum that is required here is at least 1 centimeter per hour. So, if it is less than 1 centimeter per hour for 4 hours, we call it as protracted active phase. We are going to call it as protracted active phase. Whereas this is commonly known as prolonged latent phase. This is commonly known as prolonged rather than protracted. This is prolonged latent phase, protracted active phase. Then, so I have told you what is the arrest of active phase. What is arrest of active phase? Arrest of active phase is when there is no cervical dilation. You don't see cervical dilation. In a woman in whom already amniotomy is done for a period of 4 hours, if contraction is adequate, or for a period of 6 hours, if the contraction is inadequate. This is a summary table of the whole topic. I can't make it bigger than this. So, please bear with me. So, I'll be writing in short forms for this so that we can summarize the whole chapter in this page. Alright. So, this is basically the arrest of active phase. If you have any doubt, go back to the slide and check the complete definition. Alright, there is no cervical dilation. There is arrest of cervical dilation after amniotomy has already been done. 4 hours if the contractions are adequate. 6 hours if the contractions are inadequate. Now coming to the second stage. So second stage, the newer definition. The newer definition is, I want you to just write. You are going to write, so here we have the primi column, right? So we will write primi there. So it is going to be 3 and here it will be 2. If it was the other way, it would have been easier. It will be 2, 3 plus 1 each. So in primi, it is going to be for 3 hours. In multi, it is going to be 2 hours. Plus 1. Plus 1 if she is on epidural. Plus 1 if she is on epidural. So, in primi, we will wait for 3 hours before calling it as arrest of second stage. If she is on epidural, we will wait for 4 hours. Whereas in multi, we will wait for 2 hours plus 1 if she is on epidural. This is as per the newer classification. This is the newer one. In the old one, you will find it as 1 less. It was 1 and 2. Now it is 2 and 3. Alright. Now coming to the third stage. So, third stage, there is no difference between primi and multi. The difference is as per the active management of third stage of labor. If the active management of third stage is done, the placenta has to be delivered within 30 minutes. If only passive management is done, we will wait for 60 minutes. If the delivery does not happen by now of the placenta, if the delivery of the placenta does not happen in this meantime, it is retained placenta. So here the diagnosis is retained placenta. Finally, fourth stage is 2 hours after the expulsion of placenta, where we monitor the patient. We are going to assess the tone. We will check the tone, the pulse, the BP, the bleeding. Every 15 minutes, we are going to reassess. Now, as for protracted latent phase or prolonged latent phase, we are just going to give the patient sedation, analgesics, and we are going to wait. As for protracted active phase, I told you first we are going to do ARM. If ARM is already done or if the ARM is not effective, the next step is oxytocin. So first check how is the membrane? Membrane intact, do ARM. Membrane is already gone, then go for oxytocin. Next is arrest of active phase. Arrest of active phase means here you have to go for Cesarean section. This is Cesarean section. And when we see that there is second stage arrest, we have option of instrumental vaginal delivery or Cesarean section depending on the stage. So these are the managements. So this is the management for the prolonged latent phase. This is the management for protracted active phase. This is the management for arrest of active phase. And this is for the second stage arrest. Here you have all the values. So the first stage is till the full dilation, second stage till the expulsion of fetus, third stage till the expulsion of placenta, and fourth stage is 2 hours after. And we can again divide the first stage as latent and active phase. So this is all that is there in the topic. Everything has been covered in a single slide in this so that it will help you in the further future revision as well.